Thank you, Raji. I think the last lecture in this session is Tala Meran. Tala, please.
It's always an honor to be present on this dais. My name is Dr. Talha Miran. I am a heart failure and transplant cardiologist based at Sir H.N. Reliance Foundation Hospital. Thank you, AOC, and thank you to all the organizers for inviting me. The topic given to me today is heart failure with improved ejection fraction. As we've all heard over the last two talks, thanks to all the advances in GDMT, we are seeing this more and more, heart failure with improved EF. So this is a very important topic to know about. So these are the things that we'll be discussing over the next 10 to 12 minutes. So this paper, over the last 2-3 years, there have been several sort of minor changes in the terminologies on how heart failure has been defined and just in nomenclature. This was the most recent definition for heart failure that I could find based in 2021, and this was endorsed by all the major heart failure societies across the globe. This is just the universal definition for general heart failure. Basically, it's a clinical syndrome characterized by symptoms and signs of heart failure caused by any structural or functional cardiac abnormality and corroborated by at least one of the following: elevated natriuretic peptide levels or objective evidence of cardiogenic pulmonary or systemic congestion. Now, as we've all seen over the last two presentations, all clinical trials define heart failure based on EF cutoffs, right? So it's extremely important to know what the current guidelines say. As per the AACC AHA definition, both the 2013 2016 guidelines did not make any changes, but these were the cutoffs. Less than 40% is heart failure with reduced EF. Preserved ejection fraction is more than 50%, and between 40 to 50%, they label it as heart failure with preserved ejection fraction borderline or HFpEF improved. The ESC guidelines are also similar. Reduced ejection fraction as LVEF less than 40%, heart failure with mid-range ejection fraction 40 to 50%, and heart failure with preserved ejection fraction more than 50%. So, just to simplify this, a group of experts in heart failure sat down together, formed what they called a Heart Failure Academic Research Consortium, and just simply put it there and said that these are what the subsequent clinical trials and the possible new target molecules should enroll in the clinical trials according to these criteria. So HFrEF, heart failure with mildly reduced or mid-range EF 40 to 50%, and heart failure with preserved ejection fraction. Now one must understand here this whole thing of heart failure with mid-range ejection fraction, it can just, there would be a lot of overlap between HFrEF patients and HFpEF patients. These could be patients just getting worse from the heart failure with preserved ejection fraction category, or these may be patients actually on their way to improvement. So it's a very dynamic sort of subgroup here. And so, since it is dynamic, there will be a continuous temporal change in the clinical trajectory. So, a lot of people actually consider this whole heart failure with mid-range EF as a sort of a continuous change in the continuum, and they say that the prognosis is not necessarily different just based on the EF cutoffs. There are several other complex factors that play a very important role. So, based on all the drawbacks that we know of just relying on ejection fraction to classify the heart failure subtypes, there are certain newer definitions which are being proposed, and this is I borrowed this from a recent paper in the Journal of Cardiac Failure. So we all know pre-heart failure, so patients who are at risk for heart failure, new onset or de novo heart failure, we all know about. Then this term, Dr. Karnik also alluded to this, worsening heart failure. So these are basically patients who've had signs or symptoms of heart failure despite treatment, who require escalation in therapy on an OPD basis, or for that matter even hospitalization. So that's an important target group. Then persistent heart failure. Now this is something that must be distinguished from stable heart failure. This whole term called stable heart failure should basically be regarded as a misnomer, because we know that guideline-directed medical therapy in patients with heart failure with reduced ejection fraction should lead to improvement. And so if they are not improving, that does not mean that they are stable. That means they are in persistent heart failure. We should continue to strive to optimize their medical therapy further. And then we have heart failure in remission and recovered heart failure. There's also a lot of confusion between when to use improved heart failure and heart failure with improved EF and when to use heart failure with recovered ejection fraction. I think in my mind, heart failure with recovered ejection fraction is a little bit of a misnomer, because it tells us that everything has improved when that may not be the case. Heart failure with improved ejection fraction tells us that, it's improved, but it's not really normalized. So recovered may not be the right word. So because of all of these complexities and these differences in various guidelines and various societies, there was a scientific expert panel that convened and defined heart failure with improved LVEF as any patient who has had a decreased EF at baseline, documented EF of less than 40%, with at least a 10% increase in absolute value in the EF, and a second measurement being of more than 40%. So this is what the actual current updated definition of heart failure with improved EF is. We all know that when we give guideline-directed medical therapy to patients with HFrEF, there could be both positive as well as negative LV remodeling. Thanks to the medical and device therapy, you can have reverse LV remodeling and patients can have full recovery, they can have partial recovery, or they can have no real functional recovery. It's also important to understand that this is a dynamic and bidirectional process. It can always go back from full recovery to HFrEF as well. Now, how common is heart failure with improved EF? This is just some of the data from the real world registry. These are not trials, these are just registry data that I'm showing. This is from the Penn Heart study, about 1,800 patients. They say that 10% of their patients met criteria for heart failure with improved EF, with a mean improvement of at least 28% over a mean follow-up of 28 months. Their 9-year follow-up data showed that their hazard ratio for death, LVADs, or requiring transplant was 4.1 between the HFrEF and the heart failure with improved ejection fraction pattern. Two very important points that were highlighted in this registry were that the patients with heart failure with improved ejection fractions were actually on this comparable GDMT when compared to the patients who remained with the low EF. And also, the patients, despite having an improvement in their EF in this registry, their risk for hospitalizations remains similar as compared to the HFpEF patients. The second registry was the improved heart failure registry, about 4,000 patients. They said 29% of their patients had met criteria for heart failure with improved EF, with at least a 10% improvement in LVEF over 24 months. Both of these registries had something in common. Both of them showed that these were the predictors to help in predicting which ones would improve. Younger patients, females, lack of comorbidities, and lack of myocardial infarction. This is another registry, a smaller registry, about 400 patients. They said 9% of their patients met criteria for heart failure with improved EF. However, if you look at them, over a longer follow-up of around 15 plus minus 4 years, they said that 40% of their patients went on to subsequently have a decline in their LVEF of at least 10%, and 5% still required cardiac transplant. So why is that? So what is basically hypothesized is that, maybe the recovered heart is not really recovered in full. If you look at the molecular level, the molecular signaling in the recovered heart is actually quite similar to what the failed heart had. So maybe we can consider this heart failure with improved EF as just a new steady state where the heart has sort of acclimatized to function just about adequately in the current situation. But with this new steady state, it has lesser contractile reserve, lesser biological reserve. So the moment there is a second stress or any kind of abnormality, the recurrent LV dysfunction will happen. Some of the predictors, these are some of the predictors for reverse LV remodeling. The clinical, genetic, echocardiographic, and biomarkers, some of them are really common sense. Some things that I would like to point out, especially in genetic testing, we don't generally do this as very common as it should be done, but there are certain genetic mutations, and I'll point them out in the next few slides as well, which portend a good prognosis, and there are some which portend a high risk prognosis. So when someone's had a recovered EF, what should be your clinical approach? Now, the next 2-3 slides will talk about that. So in addition to good physical examination and history taking, always continue to evaluate for their need for diuretics. We also need good imaging in terms of echocardiogram, preferably with global longitudinal strain, MRI to measure the extent of fibrosis, late gadolinium enhancement, extracardiac volumes, extracellular volumes, and in addition use biomarkers as well as genetic testing. There are certain truncation level mutations of titin which actually confer a good prognosis. If you have these certain genetic mutations, the probability of them responding well to GDMT is much higher. On the other hand, certain lamin A mutations confers a much higher risk factor, especially when it comes to arrhythmogenicity. Now, if you have heart failure with improved EF, what should you do? Should GDMT be stopped? Is there any data or trial for this? Well, there's only one sort of randomized trial that is out there. This was the TREAD-HF trial, which was published in Lancet in 2019. It was an open-label randomized pilot trial where they took asymptomatic HFrEF patients with DCM with LVF of less than 40% who had an improvement in EF to at least 50% with a normalization of NT-proBNP and the LV end diastolic volumes. And after screening, they found 51 patients that met their criteria, and they randomized them to either a phase withdrawal versus continuation of GDMT. And then as a second part, after 6 months, participants who were initially randomized to continue their therapy also had their GDMT wean. And what were their results? Basically, what they found was that almost 44% of their patients from the first withdrawal group and 36% of the patients from the second withdrawal group experienced a recurrence of heart failure. So based on whatever limited data we have, the general consensus is that, I just have 2 or 3 more slides. The general consensus is that one must not stop the GDMT. When it comes to loop diuretics, stopping them is encouraged. It helps preserve their renal function. In fact, continuous requirement for loop diuretics by the patients is considered as a sign that, as a high-risk sign that they may have recurrent LV dysfunction despite having an improved EF. Digoxin, one can stop unless there is persistent arrhythmias. MRAs, we could consider stopping. Again, we don't have good data to support that. There is some weak data supporting maybe we can switch from an ARNI to an ACE or an ARB, but as much as possible, try to continue the ARNI and definitely continue the SGLT2 and beta blockers. Here's also a very important question to consider. What about patients who had an AICD implanted already and they have a recovered EF and the battery is up? Should we change the battery? So no real prospective trials, but based on whatever real world data we have, the consensus is that yes, we should change the generator battery, especially if they have these 3 factors mentioned here.
Can we please?
I'll just summarize, sir. So this is my summary slide. So it's important to recognize heart failure with improved EF as a distinct clinical syndrome. Serial LVF measurements to track the trajectory of LV remodeling change is important in making that distinction. Heart failure with improved ejection fraction, remember, is a less pathological steady state with lesser reserves and hence more prone to recurrent dysfunction. Very cautious with stopping GDMT. Suggest individualized decision making. Close follow-up with clinical exam, ECG, echo, and biomarker testing is required. And if their patients have an improvement and they have an AICD, they should have their batteries changed. Thank you.